Hello, everyone. I am Ivory Allison, the National Director of Community Impact for the American Liver Foundation. I'd like to thank you for joining us for our Life with Pediatric Liver Disease program with our topic this evening on pediatric new protocols to diagnose and treat babies with biliary atresia. We're excited to have two amazing speakers with us today. Dr. Jorge Bezerra, he is the Pediatrician-in-Chief at the Children's Hospital of Dallas, and Robert L. Moore Chair in Pediatrics and Professor and Chair of the Department of Pediatrics at the University of Texas Southwestern Medical Center, as well as Dr. Sindhu Pandurangi, I hope I pronounced that correctly, Assistant Professor, Department of Pediatrics at UT Southwestern Medical Center. We are so appreciative that both doctors were able to take time out of their busy schedule to be here with us this evening. I want to make sure everyone knows this is a meeting. You can have your cameras on or off, whatever you feel more comfortable with. Dr. Jorge and Dr. Sindhu are going to do their presentation, and we will open it up for questions. So please put your questions in the chat. And when we get to that section, you can also raise your hand if you like to come off camera and ask your question yourself. So now I will turn it over to Dr. Jorge.
Well, thank you so much for getting us together. To me, it's a bright evening to have a chance to spend this time with each and all of you together. I like to think that this is a great time for patients who happen to have biliary atresia. And I say that because over the years, there has been a growing engagement and involvement of the parents and foundations to really pay attention to this disease, to make sure that whatever advance we witness to be translated into new hopes for children with biliary atresia, and also for their families. I want to highlight a couple of key partners that have organized to really bring biliary atresia to the forefront of the conversation. For example, the Biliary Atresia Research and Education Organization, also known as the BEAR organization. That is absolutely fantastic. They bring us together. They gather enthusiasm for us to meet and talk about this and educate families and see how else the field is evolving. We have the American Liver Foundation that is having this live webinar for us to discuss, and also to now begin to think how we can generate resources to get clinicians and investigators to study biliary atresia. So thank you all for the sponsorship of this this program and the emphasis on biliary atresia. And for me, it's a real pleasure to spend this time with you all. I see here the participants, and I want you to notice that one of the participants is nobody other than Dr. Bill Balistreri, someone that we just love and get inspired by all the time. So thank you. We call him Dr. B. There is only one Dr. B, and this is Dr. B for Balistreri. I thought that before we open the forum for discussion, that in collaboration with Dr. Pandurangi, that we will share a couple of thoughts with you. She has the most exciting things to talk about, as usual. But to start the conversation, what I will do is just share with you high-level ideas as to how we see biliary atresia and what we're putting together to continue to advance the field so that we know more about the disease and think about how we can improve diagnosis, access to care, and treatment, so that we can save livers, save lives, and help kids get better, go to school, and have fun. So what I will do is I will share a couple of slides, as I said, that have general ideas about how we are approaching biliary atresia as a platform for studies to understand the disease. I'm going to share my screen. Send request. So sharing is not turned on. So I think it's someone from the ALF that will give me the permission. All right, let me try again. Here it goes. I hope that you can see my slide. Can someone tell me if you can see my slide?
We can. You need to just put it in. There you go. Perfect.
I wanted to share with you the excitement and where we are geographically at UT Southwestern Medical Center and Children's Health in Dallas, state of Texas. This is what the hospital looks like. Currently just over 400 beds. UT Southwestern in this campus, east or west of the building. And you can see there is a construction here. That's the space that now is occupied by a beautiful new large building. It's called the Parkland Hospital that used to be in this structure here. But at Children's Medical Center of Dallas is where we see patients with biliary atresia, pre and post transplant. We have put together what we call the Biliary Atresia Research and Cure Program that begins with the patient and ends with the patient. From the patients, we collect data, tissue, blood, urine, liver, and we generate experimental models so that we can seek for novel biomarkers, both of diagnosis of disease as well as ways to monitor progression of the liver disease, as well as use these biomarkers perhaps as endpoints for new therapies, as well as the existing therapies as we see them. How do we do it? At the time that the patient is seen, we collect clinical data that includes demographics such as age, forms of biliary atresia, the biochemical parameters from blood test, urine, chest x-ray, whatever is done, ultrasound. We obtain a very small fragment of liver biopsy and stage the disease, see how much inflammation, how much fibrosis there is. We isolate nucleic acids and we do either transcriptome or we do single cell analytics, really to create a large data platform that allows us to understand what drives the disease. Can we use some of this to predict how the patient will do? What should be the best therapeutic approach for this patient? Can we customize or personalize the care? We also want to study the disease to find out new ways to tackle this disease and tame its severity. Traditionally, we have used the rotavirus-induced animal model of biliary atresia, in which rotavirus is used to infect newborn mice, and they develop the disease that is very similar to the tissue injury in patients with biliary atresia. And more recently, what we do, we get a tiny little fragment of the liver and then generate biliary organoids. And the goal is to then model the disease, the human disease, using human tissue that comes from the same patient. So this is the future that we think we are using today, hoping that this will give us new ideas about the disease. What causes it? What drives the progression? How can we intervene to save the liver? Let me see how this works to give you a view of this technology. We get a patient, we get a tiny little fragment of pieces of a liver biopsy. We miss it, we grow in a Petri dish, and then anywhere between 3 days and 28 days, we see these organoids grow. This is what they look like under the microscope. If you section, you see what the cells look like. And they emerge and appear like a sphere. So we call it cholangiocyte organoid. Most of these cells truly have features of the cholangiocyte or the epithelial cell that line the extrahepatic bile duct, and then perhaps undergo some differentiation to become cholangiocytes of intrahepatic bile ducts, or the bile ducts that are within the liver. Let me give you a chance to actually go inside one of these organoids. So this is one of these biliary organoids that have been stained. You see primarily two colors. In blue is the nucleus of these cells. And then you will see some spikes going up in green that represent acetylated tubulin, which demonstrate visually the cilium that exists in each cholangiocyte. So this comes from a small fragment of a normal liver. And as you can see, as you go into these organoids, you see the disposition of these cells that form like a sphere. And then you have the cilium stained in green that stick up looking inside the lumen of this sphere. Very nicely organized. And we said, well, what does it look like if we do the same thing, but coming from a patient with biliary atresia? And this is on the right side. When I ask you to pay attention, you can clearly see the green sign. You can see the cells and the nucleus stained in blue. But notice that the number of ciliated cells, or cells in green, is smaller. In addition, the green seems to be pointing outside the cells. So there's a malalignment or mispositioning or malpositioning of these cilium, that the cells look like they're confused. They don't know to look towards the center of the biliary organoid. So we said, wow, it confirms some initial thoughts that previous reports that suggest that patients with biliary atresia have defect in ciliation. Now, if the cells are confused and have defective polarity, the malpositioning of the cells, could it be that with the cells being malpositioned, whether there is abnormal intercellular junction? And what we did to see if that was the case, we filmed the formation of one of these biliary organoids using a microscope, and filmed it for 4 days. And you can see that these cells get together, and then they form this sphere, and they grow. And note that they grow in a fairly stable way, okay? See that growing, you have the big one in the middle, the other smaller ones on the side. Beautiful from a normal patient. On the left, you have the same type of approach. Now following the growth of an organoid from a patient with biliary atresia. Begin to film early on, but you can see that the cells begin to organize. They form the organoid. And then I'm going to ask you to notice that it contracts. It kind of, we call it puffs. It made us think that perhaps what's happening is that there is a leakage as the cells grow and they produce the liquid, the secretory component that makes the organoid grow, it can't hold the pressure, it leaks out. So we did several experiments that are summarized on this small cartoon video clip. So remember, we have organoids that are growing, they coalesce, they get organized. Let's think that we stain them, and this is what the organoids look like. If we section these organoids and look inside, in a normal patient, you have ciliated cells, and the cilium point to the center. In contrast, we have biliary atresia. These cilium look outside, they're malpositioned, and there are fewer cells with them. If you incubate them with little beads, those with biliary atresia take up beads, suggesting that they have increased permeability. What brought hope was that if we incubated these with two types of growth factors, we noticed that if the organoid came from a normal baby on the left, the number of ciliated cells grew in number, suggesting that these organoids were maturing. And the one from biliary atresia on the right, the cells begin to have polarity and also increased number of organoid. Last but not least, we have since then incubated those epithelial cells in red with mesenchymal cells, or cells that form the structure that hold the bile duct together. And what we see is that you can really see how we are almost creating a bile duct in which you have the epithelium in one side, imagine half of a bile duct, and then the stroma holding the bile duct together, and the so-called peribiliary glands. Now, our ability to generate these systems for each patient bring the possibility that we can study each patient at a time and model the disease using the patient's own tissue. Let me transition this approach that we are trying to, that we have in place to study the disease, to transition to a more clinical discussion. And just before I transition to Dr. Pandurangi, I'm going to convey one message to you all, and you probably know that already, which is if newborn jaundice is very common, and most often is a normal physiologic or breast milk jaundice, the babies do get well. The American Academy of Pediatrics recommends that if the baby is jaundiced at 2 weeks of age, perhaps be seen as a 2-week well baby check, that the pediatrician, the advanced practice provider, family physician, whoever is the provider seeing the baby, that they sent bilirubin to be fractionated. In other words, get total and direct or conjugated bilirubin. This is very important because an increase in direct or conjugated bilirubin enables you to refer the baby to the pediatric gastroenterologist and hepatologist so that they can pursue the workup for the baby so that an early diagnosis is made, because an early diagnosis increases the chance of better surgical outcome and hope to have a positive biliary drainage after the Kasai procedure. What I'd like to do now is stop sharing and transition to my colleague, Dr. Sindhu Pandurangi. I will stop sharing.
All right,
See
great.
if I can do that here. Did I already stop sharing, or I might know I'm still sharing?
I think I'm sharing now. Can
Great,
you see my
awesome.
slide?
Take it from here.
Okay, all right, okay, thank you. Well, Dr. Bezerra's a hard act to follow. I won't have any of those fancy animations in my talk, but we're going to be focusing a little bit more on the clinical and translational side of research in biliary atresia. And my hope is that I can maybe give you all some updates on where we are in the field and get you excited about what's to come and to encourage you to be involved and give us your patient and family perspective. So again, I'm Sindhu Pandurangi. I'm an assistant professor of pediatrics here at UT Southwestern. I'm a pediatric hepatologist and transplant hepatologist. During the next few minutes here, I'm going to be going through some of the strategies that we utilize to diagnose biliary atresia and review some of the screening biomarkers that we use to differentiate biliary atresia from other cholestatic diseases that we can see in neonates. I'll also review some imaging and interventional diagnostic tests that are new and on the horizon, and as well as some postoperative management strategies that have been used for biliary atresia. So biliary atresia is a challenging diagnosis to make, and some of you may have had this experience with your own diagnostic journey for your child, because biliary atresia can mimic other types of neonatal cholestasis. And so we're really trying to find that needle in the haystack when babies come to see us as pediatric hepatologists, trying to figure out, is this biliary atresia or something else? So classically, what's utilized to make the diagnosis has been monitoring for stool color, so looking for pale stool or acholic stool, and as well as laboratory and molecular testing. So laboratory testing meaning things like liver function tests, fractionating bilirubin, serum GGT, and then molecular testing is becoming increasingly common now, where we're able to send genetic panels to identify other genetic causes of cholestasis in this population. Ultrasound is commonly utilized to look for anatomic anomalies to identify is there a choledical cyst, other classic features that can sometimes be seen in biliary atresia. Some centers utilize a HIDA scan, and some centers also utilize liver biopsy to look for findings of biliary atresia. And then lastly, the gold standard is really that intraoperative cholangiogram when the surgeon goes in to evaluate and visualize the biliary tree. And shortly thereafter, if that intraoperative cholangiogram is concerning for BA, that's when the Kasai is performed. So we know that early diagnosis and early Kasai improves outcomes. And a lot of the older literature suggested that aiming for making the diagnosis by 60 days or so is the goal, but that goalpost is moving sooner and sooner. And now we know that we want to try to make this diagnosis as early as possible, as early as even 30 to 45 days of life. So some of you may have heard of the test matrix metalloproteinase 7 or MMP7. And so I wanted to review some of the literature out about that and how we're utilizing this test now. So the first study that kind of put MMP7 on the scene in making the diagnosis of biliary atresia was published in 2017. This was a study done by Dr. Bezerra's group, as well as the Childhood Liver Disease Research Network. And that study looked at babies with cholestasis and biliary atresia and looked at plasma protein levels of that were different between the groups. And in this study, MMP7 emerged as a really promising biomarker to screen BA versus non. And then a subsequent study in 2018, also Dr. Bezerra's group looked at a cohort in China. And this study was focused more on how do we utilize this test clinically and make the diagnosis by establishing a cutoff, because in order for doctors to understand lab tests, we have to have cutoffs to know what's a positive, what's a negative, what's in between. And so this study identified a cutoff on one of the assays that was utilized at that time, and overall showed a really high sensitivity and specificity for making the diagnosis. And since then, there have been studies all over the world, Taiwan, China, Japan, Europe, and the Middle East, that have confirmed that MMP7 can be a very accurate test to make the diagnosis. But in all of these studies, different assays were utilized, and there were also very different cutoff values that were predictive of the diagnosis. And thus, it kind of laid the foundation of what are we going to do in North America? There are no studies specifically looking at our population in North America, and what cutoffs are we going to utilize? So this is a paper that we recently published in Hepatology last month. And we looked at the diagnostic accuracy of serum MMP7 as a biomarker of BA in the North American population. We did this study in collaboration with the Childhood Liver Disease Research Network. And we looked at two groups of patients. Biliary atresia, so we had 201 patients with BA, and then we had non-biliary atresia cholestasis, and that was 198 patients. We also looked at two assays that are utilized in North America, a single-plex assay and the TR-FRET assay. And actually, this TR-FRET assay is what we use here at Children's Medical Dallas when we're running the MMP7 test. And we favor this assay because we can run the samples fast and it doesn't compromise accuracy. And what we found in our study is that the single-plex assay and the TR-FRET assay were equally accurate. The assay did determine what cutoff we had to utilize, though, and that the FRET assay has a lower cutoff at 18.2 versus the Luminex assay, which was at that 52.8. Overall, MMP7 has a very high sensitivity to make the diagnosis of biliary atresia. And also, our study showed that there's a really high negative predictive value, meaning that if a patient has a low MMP7 level, the likelihood that they actually have biliary atresia is pretty low, that we can feel confident that we're not missing a case of biliary atresia. We compared MMP7 to other commonly utilized biomarkers, so GGT being very commonly sent, stool color, so that was physician assessment and parent assessment of stool color, as well as liver biopsy. And we found that the overall accuracy was actually the highest for MMP7. So it actually outperformed a relatively invasive test of a liver biopsy. There have been subsequent systematic reviews and meta-analyses, meaning big studies where researchers look at all the available literature and collate it and kind of compare how good one study is to another. And from a systematic review and meta-analysis in 2021, MMP7 emerged again as a very strong diagnostic biomarker for biliary atresia. Also, GGT and IL-33 were two other markers that were reviewed, and they all performed very well. And MMP7 performed slightly better than the rest here. So what additional diagnostic studies are out there? So I mentioned ultrasound, so our study, specifically the way I think about using ultrasound in making the diagnosis of biliary atresia is actually as a way to rule out other problems, specifically looking for a colorectal cyst. A lot of the literature to date doesn't really put a lot of stock in classic features of BA to make a diagnosis. So, we hear about, is there a gallbladder, is there not? There's something called the triangular cord sign, which, in biliary atresia, above the porta hepatis, there might be a fibrous cord that's seen, that's called a triangular cord. Sometimes it's seen, sometimes it's not. So I think in the future, we're going to have to see how utilizing ultrasound plus some of our serum biomarkers might improve our overall diagnostic accuracy. And also in this day and age where AI is everywhere, there's already been some studies coming out of Asia utilizing artificial intelligence to read ultrasound. And I see a lot of power in this, where maybe you're at a center where you don't have pediatric radiologists, or you have radiologists. Biliary atresia is rare. maybe your radiologists haven't seen biliary atresia in a while. Having these additional tools can help us identify the patients who need to be referred quickly. There's also some literature coming out about using percutaneous transhepatic cholecystocholangiography. So that really rolls off the tongue. It's really, really easy to say. So PTCC, so that's an IR procedure where injected into the gallbladder, and it's almost like what a surgeon would see in an intraoperative cholangiogram. However, instead of a actual surgery, this is a minimally invasive procedure, and a pretty large series coming out of Canada showed the accuracy of utilizing this to make a diagnosis of biliary atresia, where on the left side here you can see how so that's actually a BA patient where you can't see things light up very well in the biliary tree. However, this is, even though it's a minimally invasive procedure, it is invasive and it would require anesthesia. So what's a way that we could be even less invasive? So I wanted to highlight my colleague here at Children's Medical Dallas, Dr. Natasha Corbett. She just published a pilot study regarding a new tool called FIInD Green in stool. So this looked at utilizing a contrast called ICG. And in this study, she looked at 7 babies with biliary atresia and 11 patients with other types of cholestasis. The ICG was injected and taken up by the liver and then excreted into the biliary tree. And in patients who have biliary atresia, there was no excretion of the ICG into the intestine. And therefore, when you look at the stool and the diapers, there was none of this, the release of this dye. And there's specialized infrared cameras that can be used to identify the excretion of this dye into the stool. And conversely, if there is excretion, then we know that there's patency in the biliary system, and therefore there's not an obstruction, which lowers the concern for biliary atresia. So this is a really exciting pilot study. And again, I think thinking about our resources and how we can make this diagnosis faster and ideally making the diagnosis in the least invasive way possible. This is very exciting, and using this in combination again with serum biomarkers, I think there's a lot to look out for here in the future. And I was going to briefly also touch on, I think I'm okay with time here, medical management after Kasai. So a current treatment algorithm, I think, utilized at most centers include, of course, early diagnosis and Kasai. We know that makes all the difference in terms of achieving biliary drainage. Most centers will utilize IV antibiotics in the perioperative period. We always want to optimize nutrition in our patients. That helps them, of course, recover from the surgery, but also regain some catch-up growth. Fat-soluble vitamin supplementation is critical, because as they're recovering from cholestasis, they might be overall depleted with fat-soluble vitamins, so we have to supplement that. Ursodeoxycholic acid, this helps with making the bile more viscous and can help with augmenting the drainage after Kasai. Antibiotics for cholangitis prophylaxis is pretty commonly agreed upon. And then, of course, careful monitoring for cholangitis and treatment of cholangitis if that were to arise. So, fever, change in stool color, increase in liver numbers, bilirubin, and inflammatory markers. Those are all reasons that, you should be calling your medical teams, and we should be treating. So, but what else is out there? The main clinical trial that has been conducted in the United States that has looked at treatment after the Kasai surgery is the START trial, and actually, Dr. Bezerra was the primary investigator on this trial. This was a multi-center trial with 140 participants, and they looked at utilizing steroids after Kasai. So the idea being that steroids can be anti-inflammatory, can it relieve inflammation and promote biliary drainage. So patients were randomized to a primary steroid group versus placebo. They all received IV steroids. The treatment group received IV steroids and then oral steroids thereafter. And they actually found that there was no difference in terms of overall outcomes and survival. And there was also survival with native liver. And there was also a slightly increased incidence of adverse events in the steroid-treated group. However, it wasn't statistically significant. So this was interesting to see, because also, we think about this globally too. Many other centers in Asia and Europe have also published on this topic, and we're seeing some mixed results here, that there may be a benefit to using steroids in the short term, but the long-term impact on native liver survival is unclear. So I think this raises the question of, should all BA be treated the same? So we looked at this at our prior institution, and we utilized a customized postoperative protocol. So this is where patients after Kasai were evaluated for their stool color in that immediate postoperative period. And we utilized stool grading cards. And any patient who had acolic or inconsistent stool coloring after the Kasai, we stratified them based on age. And those patients who were older, we looked back at their liver histology at the time of Kasai. And those with a predominant inflammatory presentation on their biopsies, we actually treated them with IV antibiotics and steroids. And also for the younger patients who didn't drain, we treated them in a similar way. And the patients who drained, meaning they had pigmented stools shortly thereafter surgery, we didn't give them the steroids or the antibiotics. We treated them with conventional therapy. So this is also a schematic, just kind of explaining what I already said, and then this is a table showing our treatment protocol. So what we found was that our overall rates of successful bile drainage, so the way that we measured that was at 3 months postoperatively, getting that total bilirubin level under 2, that went up significantly. It went all the way up to 80% with institution of this new protocol. And figure B here shows the moving average of successful biliary drainage dating back to 2008, and in the red, and then the blue line shows that sharp increase in success after institution of the new protocol. A secondary outcome that we looked at, though, is if there was any change in survival with native liver at 2 years of age. And this was a pilot study, so we didn't have a ton of patients. There were about 20 in each group, and we didn't see a significant change in terms of babies who are making it to 2 years without needing transplant. But I think that what was novel about this approach, and I think something that we think about in the future as we approach treatment, is should all biliary atresia patients receive the same, or should we be utilizing a customized approach postoperatively? And I think that there's going to be more in this space, and potentially even more studies utilizing this protocol where we can get larger cohorts and better data from this. So I think, what are the unmet needs and what's the wave of the future? I think of course, we need to increase access to early and accurate testing. And we need to make it easier for babies where we have a concern that they have biliary atresia to be referred to pediatric liver centers who are experienced and can perform Kasai surgeries and are comfortable with doing that. We also need better tools to identify which infants are likely to respond to Kasai. And then also, how are we going to identify who's likely to improve with therapy after surgery? So who might benefit from these adjuvant therapies to aid with bile flow? And then as we learn more, I think also what therapies can help halt that progressive hepatic injury and fibrosis that will inevitably happen after Kasai, but how can we prolong that time or slow down that process, and ultimately with the goal of halting it altogether. So I think it's this idea of the right treatment at the right time for the right patient. And this is the crux of personalized medicine. And I think that this is the wave of where we need to move with biliary atresia. And just to highlight, Dr. Bezerra talked about everything that's going on here at UT Southwestern Children's Medical Dallas with the Biliary Atresia Research and Cure program. We are working on a multifaceted data commons platform that we're calling the Liver Map. And that starting point is going to be biliary atresia, where we integrate data, clinical, laboratory, proteomics, transcriptomics. We can utilize all of this information to hopefully stratify patients better, be able to understand what categories patients fall into so that we can better treat and better predict where things are going to go. So I'll leave it there, and I'll happy to answer any questions.
Thank you so much. Oh my gosh, this is so much incredible information from the two of you. I am going to stop talking because there is so much going on in the chat, questions and comments. We definitely thank all of you for sharing. A couple of you shared your personal stories about your kids. So thank you, Ariana and Ashley and Jan and Brandy. If I missed anyone, I apologize. But I know Dr. Jorge saw a couple questions and comments that he wanted to have a couple conversations on. So we definitely want to get that conversation going.
Yes, absolutely. Can I just highlight two other physicians that join us? Dr. Sarah Hassan, and hello, Sarah. It's good to see you. And then Dr. Ahmad Amuti, that is also joining us now, a pediatric resident right here in our residency program at the Children's Medical Center of Dallas. It's great to see you all. But that is the first question I'll take, and Dr. Pandurangi will take the second question. But I'm going to take the first question and answer in a different way. I think it's Ms. Ashley Rhodes that said, why do we wait for 3 months to decide whether the Kasai worked or not? And I said, how can I use visuals instead of words to show her why that is? So I'm going to share my screen again for you all to see. And what I will do is I will share another set of slides, but in these slides, can you see it?
Yes.
So this is, each graph will be one patient. This patient here had a Kasai, and very quickly, the bilirubin dropped. Here's another one. Colored stools, we waited, and you can see that by 1 month, sure enough, the bilirubin is down. Little blip, come down again, no problem. We like that. These are all success stories of babies that had diagnosis of biliary atresia, went to the operating room, had the color returned to the stools, and sure enough, when we followed the bilirubin, you can see how they normalize all by 3 months of age. Now, I'm going to go very fast up to the beginning, brrr, like that. These are patients that had the Kasai, no matter what we did, stayed like that. Now look at this one. Oops. But look at this one. This patient still with pale stools, and finally began to drop down still within 30 days. So we can still keep you saying, oh, 30 days is enough. But sometimes no, you can actually should not lose the hope. You can continue to treat the patient, and finally the patient's bilirubin normalized, the stools had normal color. This is why most studies use 90 days, because there's a subset of the patients that take longer to improve the bilirubin. 30 days, 9 days, 30 days. This one goes 30 days, just after 30 days. This one more closer to 2 months of age. So I hope that this gives you an idea. And not all the babies are the same. Most of them, you can tell, we're all celebrating when the Kasai is followed by normal color of the stools and bilirubin that normalized by 1 month of age. But if not, work very closely with your pediatric hepatologist, pediatric gastroenterologist to make sure that everything is done to see if we can restore the bioflow for those patients. Dr. Pandurangi, there was another question. What about the feasibility and success of revision of Kasai?
I think it's always a consideration, especially when we have patients who initially drain and then they come back with maybe intractable cholangitis, or the numbers suddenly get worse. I think that this is always something that we're considering in the back of our mind, and I think that that's why getting an ultrasound as well when patients come in for cholangitis treatment can be helpful, because if there's some kind of cystic structure or leak somewhere, that would be a prime example of where a Kasai needs to be revised. So I think it's really important that we don't forget about that as an option, and keep that discussion going with our surgical teams.
Well said. Any comment, Dr. Hassan?
I totally agree with Dr. Pandurangi, and thank you so much, both of you, for these excellent presentations. It's really cool. What I would, what I was going to say is exactly it. Like sometimes we are so excited that we get cholangitis because it means that the Kasai is working, but then we get defeated if it becomes recurrent and recurrent. So always having that option of touching base with our surgeons and making sure that we are not missing something that could be quote unquote an easy fix. I think that's great. So if revision is a possibility that's going to make the child thrive, grow, and not necessarily be admitted every 3 to 4 weeks, this is something that we should explore.
Thank you. Any other question or comment?
Yeah, I do have a question, Dr. Bezerra. And first of all, thank you very much for the shout out. I was wondering about MMP7. There's a lot of work being done as a diagnostic marker and tool. However, it's always interesting to me to assess prognostic values for native liver survival. And there's some literature in this end, but what's your perspective on using MMP7 to follow up with these patients and assess their progress after Kasai?
Dr. Pandurangi has the most exciting preliminary data that any human being can have access to.
No, that's a great question, Ahmad, and this is something that I'm extremely interested in. I have looked at some preliminary data that does support that looking at MMP7 trajectories after Kasai can be telling of development of hepatic fibrosis and portal hypertension. So looking at my preliminary data just looked at baseline 3 months and at 2 years. So looking at a downtrending curve, uptrending, or stagnating. And we found that the babies who did have a downtrending curve overall did better. They were less likely to have elevated OPRI scores and less likely to have splenomegaly at 2 years. So those are our clinical markers and composite scores that we use to kind of grade the presence of portal hypertension. So my goal is, how can we actually make this even more granular? Because I only had 3 data points going from baseline 3 months to 2 years, but is this something that we should be monitoring more carefully, or could MMP7 predict some of these things faster than to the point where you're already having splenomegaly and elevated OPRIs? So great question. I think there's going to be a lot more coming there.
Thank you very much. That's a very clear answer.
We have a comment here from Jen. My 7-month-old daughter had cholangitis 3 months after Kasai, hospitalized for 3 weeks, IV antibiotics, continues to do well with her Kasai. That's fantastic. We all want that. Whenever you see at a meeting that the name Balistreri is present, you will always be wise if you ask him, Dr. Balistreri, do you want to say anything? And whatever you say will be so enriching that we'd love to hear from you. Any comment about these questions?
Well, Jorge and Sindhu, thank you very much. I learned a great deal from listening to you. And the most important thing is the amount of effort and energy by you, your team, and certainly all the parents and patients that are involved in trying to deal with this very, very intriguing but frustrating disease. So thank you and congratulations.
Thank you, Dr. B. Let me share with you. So I see no comment. Let me share with no new question. Let me share with you a recent experience. I went to a meeting in Japan, and I had the opportunity to actually see the data from one group. Imagine that. They have 100% success of Kasai. And 20% of the patients have evidence of significant liver disease during their late teens. All the others are doing very well. Is that a different disease? Is there something else that they are doing? And I could not tell by talking with them, except that it felt like they never gave up. If a patient develops cholangitis, they stay on top and they do everything they can. If the patient has any increase in bilirubin from antibiotics to orso, very selected revisions, they are very intense, and the patient stays in the hospital for as long as it takes until the patient turns around. So I'm sure that we have a lot to learn from them and from each other. So it's great to see that everybody is putting their heads together to find ways to better treat babies with biliary atresia.
Yes. Oh my goodness. Thank you so much. This was such an exciting program this evening. Myself and Morgan are messaging each other, so excited. Dr. Jorge and Dr. Sindhu, you did a phenomenal job leading this. Thank you to Dr. B and Dr. Anuti, who have participated in past programs with us. So we are thankful for them joining us, and Dr. Hassan for joining us this evening. I'm not quite sure all of the parents on the call know how incredible and how special tonight was to have so many doctors at your disposal this evening to be able to ask as many questions as you would like. So thank you all for sharing this. Yes, we love that, Doctor. Yes. I'm not sure how good I am. I think I'm good. Guys, we're gonna this will be shared on our YouTube channel. We will also be placing this in our pediatric liver disease private Facebook group. We can definitely continue that conversation over there. We're so excited for our upcoming BA Day program in December. More information will be forwarded for all of you to join us. And then we will invite you guys to share with us ideas and suggestions for other topics that we should do in 2025. If you have topics, we're thinking of a program led by parents themselves, a program led by parents, which we think would be really exciting for 2025. So I just want to thank everyone, and hopefully you were able to receive Anja Meyer's email with the poster that they talked about. If not, we will share it with everyone when the recording is complete. And so again, thank you to all of you. We hope that you all have a great night, and we look forward to seeing you all in our next upcoming program. Thank you all so much.
Thank you, LF.
Thank you so much. This was great.
Yay.